Senior housing traditionally has been a private pay model where families and residents get out their checkbook and they pay the monthly rent to stay in these supportive environments. 20 years ago, the assisted living waiver program in California has been in existence 18 years. So basically 20 years ago, the state of California and many 30 other states recognized that senior housing has a place within Medicaid services, that it is a viable, wonderful adjunct to traditional health care. And the reason why I am still separating senior housing from health care is that in a senior housing community, unless a physician is coming in to perform a house call or home health is coming in to provide in-house physical therapy or occupational therapy, there is no medical services provided in a senior housing community.
Hello, welcome to Deep Current by Oceans. I'm your host, Kaylor. Today, I'm joined by Debra Draves, President and CEO of MasterCare. Deborah, why don't you walk us through your background, who you are, and what you're doing right now?
Well, thank you for inviting me, Kaylor. Good morning. My background started with healthcare. I started selling total hips and total knees for a large orthopedic conglomerate. I would not scrub, but I would be in the OR, kind of like this. How do you like the torque of that drill, doc? That was me. I was bringing in instrumentation to 8 of the largest hospitals in downtown Boston. From there, I kind of followed patients home, or at least to lower levels of care setting. At that time, it was quite common for patients to be in the hospital for a couple of weeks post total hip replacement. But things changed. And so I transitioned into the home health care industry. I sold durable medical equipment, home oxygen, and ultimately home infusion services. After that, I got involved with skilled nursing. So I'm kind of following the patient all along their journey. I took a large consulting initiative with a very large skilled nursing chain in Northern California and in the West. There were 33 skilled nursing buildings, and we built the brand. We educated key professionals within each facility, the administrator, the DON, the director of rehab, the admissions coordinator, on how to conduct compelling tours, how to develop occupancy. So always on the sales and marketing side of things, until my own grandmother needed non-medical assisted living services. Now, I knew the whole healthcare side of the equation, but I didn't know the private pay side of taking care of older adults, the assisted living, the memory care component. And I was very skeptical. I was not a willing participant in the transition of my own grandmother, but because of the way she blossomed in the right environment, surrounded by friends and engaged and with a purpose every day, I absolutely fell in love with the senior housing industry and the fact that it could give an older adult a whole new next chapter to their life. So I promptly switched gears and went from the healthcare side of things into the private pay senior housing side of things. And I worked operationally for a very large nonprofit in Northern California for several years, running their sales and marketing. Through financial crisis, it was not a pleasant time to be involved in senior housing. And I've never really gone back to healthcare. In senior housing, one of the key problems is helping families understand the service model, helping families understand what's available, the differences between a large community, a small community, assisted living, memory care, independent living. There's not really a good resource that doesn't claim the inquirer as a lead, where your phone blows up immediately. So my business partner and I built a platform to help educate California families in an open source manner, very similar to apartments.com, about senior housing. It was a subscription model, and we were doing quite well. Uh, we were generating 600 to 700 website visits and chats a day. However, and this is the big however, 68% of all that traffic in 2019 could not afford assisted living, either memory care or assisted living in the state of California. 68%. Now, that was 2019. Today, it's more like 74%. And just because as a family, you cannot afford assisted living or senior housing doesn't mean that your family member or you don't, don't require it. And so in 2022, the state of California put together a program that completely overhauled their Medicaid program. And within that program called CalAIM, there was a program called Nursing Facility Transition Diversion to Assisted Living. It has since been changed, of course, because that name wasn't lengthy enough. Now it's changed to Assisted Living Facility Transition. But the idea is that the Medicaid program subsidizes the cost of lower levels of care. What that means is Medicaid is paying for vulnerable Californians to transition either from skilled nursing into assisted living environments or from the community as a diversion because they're at risk for institutionalization. That's a big introduction, but that's what we're doing. MasterCare was founded to provide these services from the policies and procedures up in 2021. We took our first patient in 2022. So I started with my business partner and myself in 2 California counties. Today, we serve 47 counties. We're contracted with 11 different managed care plans. We have over 5,000 patients on service, and we just hired our 132nd employee.
Excellent. You say that's a big introduction. That's exactly what we're after. And that is an excellent segue into my next question because, Deborah, when you describe what you're doing versus what you were doing before, you seem to draw a bit of a line between healthcare and what you're currently working in. So my curiosity here is, do you consider them part of the same thing? Do you consider assisted living something inside of healthcare, on the edge of it? What is the relationship there, and why do you speak to them about them in different terms?
That's an excellent question, and that's the source of the majority of our challenges. Uh, Senior housing traditionally has been a private pay model where families and residents get out their checkbook and they pay the monthly rent to stay in these supportive environments. 20 years ago, the assisted living waiver program in California has been in existence 18 years. So basically 20 years ago, the state of California and 30 other states recognized that senior housing has a place within Medicaid services, that it is a viable, wonderful adjunct to traditional health care. And the reason why I am still separating senior housing from healthcare is that in a senior housing community, unless a physician is coming in to perform a house call or home health is coming in to provide in-house physical therapy or occupational therapy, there is no medical services provided in a senior housing community. It is social. It is a social environment. So When I separated, it's licensed differently. So a physician's office is licensed by the Department of Healthcare Services. An assisted living provider is licensed by the Department of Social Services. And there is a big line of demarcation. It's pretty much church and state. The only problem is to best manage an older adult's change in condition or changes in care needs, you need to blend. You need to braid those services together. So the tagline for MasterCare is senior care, health care, managed care, meaning we braid together private pay senior care, healthcare services, which we all understand, and then the payment source, which in California is managed care. But that could also be straight Medicaid in other states. Does that
I'm
make sense?
very, it does perfectly. And I think it's something that honestly, I probably haven't heard about before. Even talking to people who are in this industry quite a bit, it's probably something that is not highlighted quite as often. And it does bring me to my next. Let's say it's not a question, but I really want to get your insights here. I imagine you're also dealing with claims. The current trend is that claim denial rates are rising. They hit almost 12% in 2024. They continue to rise since then until today. There are many common reasons why that happens with the wrong modifiers. People just don't understand the process, missing authentication, incorrect codes. So, what are you seeing in terms of claims and how are you dealing with that?
So the claims process is integral. That is how we get paid, and we actually use an outsourced company to facilitate our billing and our claims reconciliation. But one of the growing issues that we have had to put policies and procedures and actually resources on center around the whole idea of eligibility loss of Medicaid. Uh, our average patient is 72 years old and older. A vast majority of our patients have cognitive issues, get their mail in one place, which means their Medicaid redetermination paperwork is going one place and they're actually residing in an assisted living in another place. Without that redetermination paperwork resubmitted in a timely fashion, the member or the patient can lose eligibility. That is a huge problem for us. And chasing down that eligibility once lost is terrifying because here we are in the middle of dropping claims not only for care but for an entire housing, food and housing. They're living in an assisted living. So if they lose their eligibility, they could face eviction. So it is not just the issue of us getting paid for our services, but it truly can affect someone's homeless status. Uh, the second issue, of course, is reauthorizations. We're contracted with multiple managed care plans in California. Each county has its own menu of different managed care plans. We provide multiple different service types and reauthorizations for all those variables all vary. So some of our authorizations are 90 days, some are 12 months, vast majority are 6 months. That reauthorization cadence is also a challenge. Modifiers are not our biggest challenge because we aren't billing for a vast array of codes. It's a very small set of codes, but eligibility issues are huge and reauthorization issues are an ongoing challenge.
So, is that the reason why you mostly currently outsource that? Is that the common practice for companies in your service line, let's say?
Um, it was a decision from the very beginning for us to outsource since we weren't healthcare providers. We came from the private pay space and our familiarity wasn't with dropping claims with managed care. We went ahead and outsourced to an expert, and it was an exceptional decision.
Great. Well, it sounds like that was the right path. Have you reconsidered doing that, or is that the way that you will continue to do it forward, at least for the short to midterm?
Well, the president of our billing resource actually joined our board, and we are their largest customers. So it is a very symbiotic, wonderful relationship that I'm not going to mess with.
Got it. That's great. Well, I want to dive a little bit deeper into who you are and what you're doing day to day. So, if you could describe what your typical week looks like, what's taking up most of your time, maybe even what you wish wasn't taking as much of your time.
Ah, well, we are from an enterprise strategic standpoint. On my whiteboard is how do we leverage the successes that MasterCare has had in the state of California in other states? And I uh, I am constantly analyzing the best next flag to stake in the ground. What state would be best? I'm happy and proud to announce that we are officially in the state of Nevada. Um, this is recent. Within the last few days, we have opened our office in Nevada.
Congratulations.
Um, but as we look at expansion outside of the state of California, we are also seeking investment partners. And as we seek investment partners, I'm kind of always nodded to be in those investment introductions. So right at this moment, I'm a vast majority of my time is talking to investment bankers and potential alignment partners to facilitate our statewide expansion. So that's huge. I am not on the day-to-day operational side. My business partner is an operational monster, and so the boots on the ground operation of our company is actually through our COO and our management sources. So I'm involved in finishing our care management platform. We have built a care management platform from the ground up, and we're just about ready to launch version 2.0. So a large majority of my early morning hours are in discussions with our developers. So that's my day. it's, it's
I'm actually very surprised to hear you say that you're so involved with your current developers. But I'm also curious about what operations would look like for a company like yours. And I know this you're probably not the one running it day to day, but
oh
still, what goes into that?
so not only is the model for MasterCare built into this whole idea of social determinants of health, which is a Medicaid trend right now, either social drivers or social determinants of health. And the definition of that is the Medicaid program will invest in, particularly for high utilizers. These are high healthcare consumers. The Medicaid agency will invest in social determinants of health, meaning non-medical situational circumstances. So non-healthcare related, but circumstances that directly affect how much healthcare a managed care member is consuming. So an example would be a newly homeless fellow who is living in his truck is probably not accessing his primary care physician appropriately. He is going to the emergency department whenever he's cold, hungry, needs to charge his phone, has a wound on his foot that could be otherwise managed by a primary care physician or an urgent center. He'll go to the ED. And so in California, the CalAIM program assigns an enhanced care manager, a non medical advocate, to go out, knock on that truck door and introduce that managed care member to a whole array of community-based resources. Things like housing navigation, housing sustaining, medically tailored meals, a whole array of services that typically the member has no idea exist and there would be no understanding how to access. Along with, let's get you a primary care physician appointment. If you'd like me to, I will uh, accompany you, because in California, primary care physicians under the Medicaid program average about 8 minutes per patient per visit, 8 minutes. So we need a strategy. So we'll work on a strategy and I'll go with you. And along the way, that person may decide smoking is too expensive. Well, the enhanced care manager has resources for that. And along the way, the patient may decide that they're sick and tired of being sick and tired. And so the enhanced care manager will take them to a meeting, a substance use meeting. So that's social determinants of health. That's CalAIM. Part of that, another example, is an older adult, say a 73-year-old lady who is living in skilled nursing because she cannot afford private pay assisted living. So she has cognitive decline to the extent that she cannot shop for herself. She cannot manage her own meals. She's not safe in the shower. She cannot manage her own medications. All of those are non-medical needs, but because she can't pay for assisted living or memory care, she's living in a medical facility for financial reasons. So what MasterCare does is we identify and perform an assessment on that lady. We then go out to our database of assisted living providers in the state of California. There are 8,000 of them. And we carefully match her care needs, her social needs. She may have language needs, cultural needs, lifestyle needs. She may have a pet. She may smoke. All what type of environment would feel like home? And then we present that prospective resident to the assisted living provider. The assisted living provider comes and assesses. We negotiate the rate. Then we package all that up and we submit it to the managed care plan to help subsidize that transition. So the managed care plan is, on average, paying about $13,000 a month for a 73-year-old lady who has no non-medical needs. We can transition. The average assisted living in the state of California is $6,250 a month. Our average transition saves the state of California, California Medicaid, managed care, and California taxpayers, and CMS, by the way, because Medicaid is federally funded to a degree, $6,700 per transition per month. Right now, we're saving the state of California about $13 million a month, and we're just getting efficient. That's how the program works.
It sounds like there is so many verticals that you're constantly juggling. So I'm very curious as well. Do you consider the development of your platform part of the operation, or you separate it into a different category when you're looking at how things are running, making sure that everything's going according to plan, and in taking you to the next best step?
You mean our new care management platform? When you
Yes.
platform, um, it's the DNA of our company. It not only manages each patient record, so we're able to see the work that's being done from a patient record standpoint, but the KPIs associated with each field care navigator, how efficient our billing is, and also then tracking the how much we're saving along the way, because at some point we are positioned to be a value-based provider. Value-based insured savings is where we want to be. We want to evolve out of a per member per month reimbursement model to more of an aligned incentives partnership with managed care. Now, there's one other aspect of this that I want to emphasize in this landscape of AI and telehealth and remote patient monitoring. The reason why we are as successful as we are is that we do not rely on AI, telehealth, or remote patient monitoring. Our model, our service delivery model is boots on the ground, in person, person centered care. The reason is our average age is 72. Our patients are typically plagued with audio problems, are distrustful of phone calls and telehealth. It doesn't work. And o- our field care navigators need to lay eyes on our patients. You need to see the environment they're in. You can't there is technology to evaluate gait and balance, but when you're trying to facilitate that on an individual that cannot manage uh, the technology, you need to be in front of that patient. You need to see, you need to hear what they're saying to you. You need to be able to observe their skin color. You need to be able to observe their gait, their balance. You need to be able to observe the aromas or the odors in the air. Is this the right environment? Because we're not only advocating for the patient, we're also advocating that to make sure that the payments made by managed care are of good value. So is that assisted living provider a competent quality provider? You can't do that remotely. You need to see and smell and hear and observe. So our model mandates that our field care navigators live and work in the communities where they are stationed, which mandates a huge amount of logistics and coordination. So, going back to our care management platform, that's why it's so critical. Long
That is
answer. Sorry.
That is beautifully put. I mean, just the way that you describe that, it almost, I mean, not almost, it sounds like this is something that is shielded away from ever being threatened by AI for a very, very long time. But still, being that now that you mentioned that, right, artificial intelligence, it sounds like you've at least dabbled with it or considered it or that the conversation has come up. But
Well,
what has that been like?
so our our hierarchy in our company is a pyramid where the patient is at the tippy top and the field care navigator is supporting that patient right underneath, and then everything else in our organization is the foundation to facilitate that relationship. So we have remote care navigators that provide all the administrative and clerical work to support that in-person care. Under that, in our platform, our assessments are there's all kinds of AI in our assessments and our care planning that are suggestions and pre-populated, and it's a AI driven assessment process and care planning process, but the actual assessment itself is done in person. So you can collect all this information, then you leverage the technology to give you all kinds of options to better manage that person in person.
Yeah. So you're using it not as a crutch, not as a primary model, but just as support, essentially,
Support.
which I think it's exactly the right way in which you should be looking at this. I'm very impressed about the approach. And actually, I mean, this is a bit of change of subject, but you did touch on something before that I want to make sure I don't miss,
Okay.
which had to do with building efficiency. Maybe it is related, maybe not. I mean, I don't know which tools you're using, but I'm very curious because it sounds like the revenue cycle is a challenge when it comes to healthcare. Sometimes, for example, the work gets done, the patient gets seen, but a significant portion of that practice is still in the air. The claims, the denials, the write-offs. What are you seeing in terms of that in your specific context?
Well, one of the reasons why we built our own platform was to better control that. Uh, the um, the platforms that were out there. Remember, we're in non-medical environments. We're providing non-medical care. So an HR system right out of the gate doesn't have components that really suffice for the types of services we provide. We needed something that we could easily adapt to any remote device and be secure. Um, and all of that needed to support the metric system that allows us to guarantee that we're getting good value for those assisted living placements. And so that's all required our own platform. It's been a heavy lift. It's not a day at the beach at all, building your own system, because you're constantly straddling from the original legacy system that you started on to 1.0. Now we're going to 2.0, and while we're launching 2.0, I'm in the process of the enhancements of 2.1, 2.2, and it's a heavy lift. It's a lot, but it's
It, de-
necessary for us to truly be able to capture everything that we want to do. And then the last piece is we are non-medical providers in the healthcare arena. We work in managed care. The measurement for managed care, the currency is data, right? That's the currency of managed care. So early on, we decided we would go after NCQA accreditation. Well, you need a comprehensive platform that can capture HEDIS data. And so that's baked into our platform. And eventually, when we're value based partners, we'll be able to share data through API.
Got it. There's one specific question I typically like to ask. Um, but in your specific case, I might give it a bit of a switch because I love to always learn what you personally feel is working great, like that you nailed down. Actually, I'm still curious because you've mentioned so many things that it seems you found the perfect mix, at least for what's working right now for you, that I'm very impressed with. But if you had to pick one that you can say, this is what I'm most proud of, the way that we're doing right now. And then I'm going to have a follow up question to that, but let me start there.
The thing I'm most proud of is that we're able to support solid relationships between our field staff, our field care navigators, and our patients. These are Medicaid patients. Medicaid patients in the state of California, as I mentioned before, are used to going to the doctor and getting 8 whole minutes for a visit. During that time, and it's not the physician's fault, it's reimbursement is it mandates that it is a volume-based business. But during that time, these individuals are not looked at by the physician. The physician is documenting on their computer the entire time. And so we made a decision, the leadership of MasterCare made a decision early on that we were going to provide impeccable service to our patients, meaning not just DMV level customer service, not just good customer service, but the best customer service we could provide in person. And I'm really proud of the relationships, and this is uncontrolled, right? Our patients don't come into a clinic. It's not a controlled environment. I'm sending staff out into people's homes, into shelters, into assisted living environment. Nothing's controlled. I'm so proud of the fact that our staff is empowered to establish a relationship with that patient and help them navigate through some of the biggest challenges that they have in their lives or that family has in their lives. There's all kinds of emotions. There's all kinds of emotions when you're having to place somebody in memory care, and we are able to support not just that patient, but their family. And that's not by accident, that's by design. And it is not, every single case is a different circumstance. Every single case is different. So I'm very pleased that we're able to support our team through that. And that was not by accident either. We put a lot of time and energy into building our team, which is scattered throughout the West.
Well, yeah, I mean, I think that's great. I heard a lot of things that you're doing very well, but yes, that's probably the deepest one I've heard so far. But on the flip side, then, this is the edge to that question. What is a challenge or a problem that you're facing now that you wish you could just snap out of existence? Like, forget about tomorrow.
Well, we are in this sort of gray area of healthcare. The managed care plans are learning about the services that are available in a non-medical environment. They're in the process of understanding and learning, but they're not there yet. And I do not mind being on the cutting edge of that educational process. But I wish I could snap my finger and not have to justify or explain and explain and explain. I wish that it was more readily adopted. We've been doing this now. We're in our fifth year. It's been an enormous growth, just an incredible ramp. And the managed care plans have amazing champions within the plans. But then there are some that are just not, that are reluctant to look at our data, to look at our outcomes, and to provide the service for their members. So it's not a mandated program within California for the managed care plans. It is optional. So it's frustrating that not all the plans see all the data the same way.
That's a really good one. And what if you took an inside look? What is the biggest time loss or time hole that is eating away at your team's bandwidth, especially on the operations side, if that's something that you're aware of?
The eligibility issue is chasing down eligibility is one of our top challenges. The in second to that, one of the mandates of the program is that the patient must have some income, some monthly income. So it's not 100% subsidy at all. It is a partial subsidy. The patient to participate must contribute what they can, 90% of their monthly income, to the assisted living as room and board. Chasing down income and proving income, or uh, uh, coordinating with Social Security, if the password for Social Security, nobody knows what it is in the family. That is a huge challenge. So I have field care navigators going with our patients to the Social Security office and sitting for hours. It's part of the deal, but that's another source of frustration. There was an easy wand. If I had a Social Security income wand, that would be wonderful.
A lot of what you're doing relies on this very efficient platform, right? That you've been describing, that you described as basically the DNA of your current company. But if you had to give an advice to, say, a new practice administrator, a physician owner, a maybe even a startup in this space who's starting to think seriously about modernizing how they're doing things, where they could leverage both technology, but at the same time continue to do things in an organic fashion, what would you tell them? Where would you tell them to start?
Well, it all depends the type of practice. If it's a traditional Medicaid practice, there are wonderful technologies off the shelf. If it is in this social determinant of health practice, our platform is designed to be white labeled. We've done all the heavy lifting on it, and but there's also competitors as well. So there's lots of off the shelf technology. It's just make sure that the platform is comprehensive enough for what you're the services that you're providing and where you want to grow.
So, Deborah, we typically like to close with the lightning round. We have a few minutes. Just would love to hear your insights very quickly. First thing that comes to mind, a minute or so per question. But let me start with this one. What is the most overrated thing in healthcare technology right now?
It's a toss up between telehealth and remote patient monitoring. Uh, I am I am a big proponent on being able to assess a patient in person, skin tone, cognition, balance. Of course, I deal with older adults, and so I'm partial to face to face. But I think uh, so much is lost on the telephone, and electrodes and capturing diagnostic and the modality of remote patient monitoring is great as an adjunct, but
I had a
not.
hunch. I had a hunch you were going there.
Yeah, it
Just-
was kind of obvious.
yeah. So, what is the one system your operation currently couldn't run without?
I'm sorry.
One system, the one system that your operation couldn't run without. For example, let's say claims are covered with the fact that you're outsourcing. What is something else that you absolutely need to have today?
Oh, we utilize and a we use a voice over IP system called Ring Central, and we utilize. They have a messaging center inside. It's like a Slack system. It really is kind of all integrated into our care management platform. It layers on top. Without Ring Central, we would have to find something to replace it. But we use it as voice over IP. We use it as our Slack system. It is our messaging system, alert system. It is how we communicate to each other.
What is the best advice you've ever gotten about running a healthcare operation from somebody else in your space?
Oh, data is the currency of managed care.
Great. That's perfect. And one last question. What would you be doing if you weren't in healthcare today?
I would be finding ways to subsidize senior housing for members in need, for patients in need. I would be raising. I'd have a foundation, and I would be bestowing grants so older adults that need assisted living and memory care services could access those services.
Perfect. I think with that excellent response, we're ready to start concluding. Deborah, really appreciate how specific you've been, how you described your passion for this industry. That's something that's coming across from the distance. Where can our listeners find you or follow what you're building and continue to be in touch with Debra Draves?
So, Master Care Plan is our URL at mastercareplan.com. It relates to the fact that every single patient is covered by a comprehensive master care plan uh, that is not siloed to healthcare or siloed to social determinants of health, but is a comprehensive plan that incorporates environment, financial, cultural, social, and medical. So www.mastercareplan.com.
Appreciate it, Deborah. Well, Thanks everybody for listening to Deep Current. If you're a healthcare operator dealing with any of the operational challenges that Deborah discussed today, or want to do things as she's doing it and are looking for ways to incorporate that into your operation, we'd love to continue that discussion. You can find us at oceansco.com. Until next time.